All right. Just got a few people coming on in. So thank you for waiting patiently for us tonight. Welcome all to Transplant Talk Live, Arrow the Bone Marrow Transplant Foundation's webinar series. These webinar series are an opportunity for us to delve deeper into a number of BMT and stem cell related topics, with tonight's webinar focusing on CAR T therapy. I'm Angela. I've recently joined Arrow as the new Patient Liaison and Communications Officer. I am joining you today from the traditional lands of the Wadawurrung people in Geelong region of Victoria. I have with me today our wonderful host, Yvonne Panek-Hudson, who is a clinical nurse practitioner in haematology at the Peter Mac Cancer Centre as well as the Royal Melbourne Hospital. And she's also the co-host of our fabulous and very informative podcast, The Straight and Marrow. Yvonne is also one of the directors of the Arrow board and is joining us today from Naarm, in the traditional lands of the Kulin Nation in Melbourne. Along with Yvonne, we are very fortunate to have two wonderful guest speakers. We have Nicole O'Leary, who is a nurse practitioner at Peter Mac, and we also have Karen Maddock, who has over 30 years experience as a haematology nurse, and she is coming to us from the lands of the Gadigal people of the Eora Nation, Sydney. I will shortly hand over to Yvonne, who is our host, but we will also be facilitating a Q&A at the end of the session once our guest speakers have finished presenting. So please pop any questions that you have into the Q&A panel. Please just make sure that you don't pop in any questions that are specifically relating to your own health issues or diagnosis, as we are unable to answer anything specific. So we please do urge you, if you have anything specific, to contact your treating healthcare team. You can also chat amongst yourselves using the chat panel, and we look forward to chatting at the end of the webinar. So without further ado, I'd like to hand over to Yvonne.
Thanks, Ange, and welcome to Arrow. It's been wonderful you joining us as part of our team. Without further ado, and thank you for the introduction, I would like to introduce our two guests tonight. Now, you may have noticed that one of our guest speakers is not Sam van der Linde. Sam, unfortunately, had a personal circumstance that precluded her from presenting tonight, and the wonderful Nicole O'Leary, who you would have heard at webinar 1 in this series, has stepped in and will be talking about patient preparation. So Nicole is a nurse practitioner at the Peter MacCallum Cancer Centre in clinical haematology, and Nicole has a special interest in the management of people pre, during and post CAR T, but I think you really enjoy the post CAR T management, don't you, Nick, and the more longer term follow-up. Thanks a lot for stepping in and joining us tonight. Our second speaker, who will be talking about apheresis, is Karen Maddock, and Karen is a trailblazer in CAR T nursing and really has led the way and really formed a lot of the models of care, both for nursing and patients in the CAR T programs across Australia. She started as a haematology clinical nurse consultant at Westmead Hospital in 2007 and went on to gain her master's in nursing in 2019 and is currently the cell therapy nurse practitioner at Westmead Hospital. And Karen is the joint chair of the ANZ TCT Nurses CAR T Cell Group and also part of our Nurses Committee. So welcome to both of you. Nick is going to go first. She's going to screen share her slides. I encourage you to put your questions in the Q&A. As Ange said, chat amongst yourselves in the chat section. I'm sure there are people you know online. And I look forward to posting your questions after our two presenters. Thanks, Nick.
Thanks, ladies. Okay, are we seeing my slides?
Yes.
Yeah. Okay, great. So thank you for the introduction and for having me. Just as Yvonne's already mentioned, slide credits to Sam, who couldn't be here tonight, but you get my voice instead. So this is an absolute pleasure to be talking about and a passion project of mine, because for those of you who may or may not have been exposed to CAR T-cell therapy in any capacity, it's an incredibly complex therapy, as many of our hematology treatments are becoming. And so really in part of this is preparing both the patient and the support network. And not just at the time that we meet patients, but throughout their journey. So in the preparation for CAR T, in the acute phase, and in that longer term follow-up, we're always preparing patients for what's next. So we'll talk a bit about some of the logistics and the step-by-step wise in terms of how patients are treated and how we prepare them, the importance of psychosocial supports in preparing patients and their support team, and some of our keen interests here at Peter Mac are optimization of patients in the lead into CAR T, and we'll talk about that, and of course how we can support the support network. So this is a step-by-step diagram that gives you an overview of where patients are on their journey. So when patients are referred in, there's obviously multiple steps prior to this that I've discussed in the previous webinar, including referral, eligibility, screening, disease assessment, lots of internal questions about confirming eligibility. So getting to this first point is the collection and apheresis. And so Karen will talk about the technicalities of collecting the cells, but even that lead into this point, the patients are needing a lot of education and support for this step-wise approach that happens here. So after the patient cells are collected, they are shipped generally mostly overseas to be made or manufactured. And during that time, patients receive treatment for their disease, lymphoma, leukemia, in the future myeloma. And we call that bridging therapy. It's a bridge to get you to CAR T. And so we use that time not only as a time to treat and manage the disease, but optimize a patient, both in terms of their performance status, but also preparing them in terms of education and how best we can support them. So whether that's linking in with social work, psychology, and really thinking broadly how we can support them and their support network. So prior to giving CAR T-cell therapy, we give chemotherapy generally as an outpatient to prepare the body for the CAR T-cells. And this is generally given over 3 consecutive days. And so that has a component of education for the patient and the carer, what to do if a patient gets unwell and where to come to and how to be managed. Obviously, there's lots of medications that are either continuing or new additions to treatment. Most of them are preventative medications that are really supporting the patient in terms of their immune function for when the blood counts get low and the immune system suppressed for a period of time. And this point here, who to call and when, this is the key, most important thing. And this isn't just at the time of post, particular time frames. This is, patients need to know when and where, when they need to escalate their issues at home and who to call and when they need to attend hospital. And so for us here at Peter Mac, 3/4 of the patients that we see are from external sites to Peter Mac. So they may be interstate, regional, or they may be metropolitan. And so part of this preparation that Sam and I provide is really reorientating them to a new service so patients can feel well adapted and understand the process of escalation. I've already touched on psychosocial support. So given that CAR T is indicated in relapsed refractory diseases, This is a huge component of the preparation and the screening that are needed for our patients in the support network. The other component is relocating. So I've already mentioned that the majority of patients aren't metropolitan or close to or from local Peter Mac. And so for many patients, it requires a relocation for up to 6 weeks in the post-CAR T period. And so thanks to amazing funding mechanisms through the state-based travel schemes and also the drug companies that supply CAR T, patients aren't out of pocket for the travel and accommodation costs. I mentioned here about optimization. So this is really a big area of interest for us here at Peter Mac, and it's something that is well researched in allogeneic stem cell transplant, autologous stem cell transplant, and major surgery. And we're looking at how we can optimize patients leading into CAR T while their cells are being made. And that's multimodal. It's including physio, occupational therapists, psycho-oncology, and nutrition, and thinking about how best we can get patients to treatment to hopefully reduce the duration of their inpatient stay and response to toxicity and their later recovery. A big component for what we do is education about infection prevention, why it's important that patients are on preventative medications or prophylaxis because they have suppressed immune system and low blood counts for a period of time. And that's something we do at every single contact point throughout the CAR T journey. This is particularly important in the later post-acute, so for patients beyond CAR T, because we see the highest incidence of types of infections in the month 1 to month 12 after CAR T, predominantly respiratory based. So for most patients, they're back in the community, getting back into regular life. So it's really about educating what their risks are and what to do to prevent that as much as possible. So the carers are an incredibly important part of this whole process for multiple reasons. So extra set of eyes and ears for complex education, information, and the logistics that are involved with the care. It's also about, the day-to-day support, but we also need to be caring for the carer, and that's why all of this preparation and screening is so important at all phases. Now, we might just skip on in terms of, Sam's a bit more tech savvy than me, so you might see a few highlights here. So these are some of our internal based materials that I can direct you to, and you can actually find this CAR T cell therapy booklet on our website at Peter Mac, or just search CAR T booklet. And the booklet gives you a step-by-step broad overview of everything that's involved in the particular phases of CAR T. And so what we encourage patients and carers to do is have a read of that before we meet them for the first time. And then we continue to discuss what the key information is based on the timeline and in terms of side effects or potential toxicities. For those visual people like myself, we've got a number of videos that are available on YouTube. This is also on our website. And again, a lot of the cancer centres that are posting these videos are the most reputable information sources if you are looking on YouTube. The other thing we know about CAR T is there is some acute toxicities that are directly related to the CAR T. So this is our alert card that we've developed for all of our CAR T patients. They keep it in their wallet, and if they're needing emergency or an unplanned admission, they present it. It has our service phone number, and the presenting team members ask to call us ASAP. So they're just some of the materials that are available. You can all have a look at them online. So I've already touched base on the importance of preparing patients and their carers, particularly given the complexities of disease to date. We also need to acknowledge that cancer is just one part of a patient's journey. We're all human. We all have complexities in our life. Some patients still working, not having a stable income. There's lots of things that we need to be screening for and really looking out for in the patient, not just the clinical side of things. And so in terms of our service here, we have a psycho-oncology service. And for those patients that are 26 years or younger, we have a youth cancer service that's available within Victoria. I've already touched on the accommodation and travel, so I won't discuss that any further just because of time. But this is one of the big factors that we've worked really hard with support service like Rare Cancers Australia to advocate that the drug companies are providing the funding and the out-of-pocket at an upfront cost rather than patients pay and then reimburse. Because as you can imagine, for 6 weeks accommodation for a 2-bed flat or a 1-bed flat nearby to the hospital could be incredibly expensive and causing a lot of issues for patients. So I'm happy to share these slides beyond, but I've covered most of this. This is just relaying the support that's available. It is all relevant to where a patient lives. I've mentioned the state-based travel schemes, and then also it's really linked in with the drug companies. So I've talked about this already. The majority of the patients that we see here are from external to Peter Mac. So this is really part of Sam and I in the nursing team, a focus of really getting to know patients quickly and preparing them and making them feel supported in an unknown environment, because it is quite rapid when we receive a referral, getting them here to Peter Mac and progressing things as quickly as possible. And so this is the distribution. This is our internal database. Now you see that there are other states that now have CAR-T available. This data dates back to 2019 when we were the only site initially delivering CAR-T cell therapy. But with some indications that aren't available in some states, we're still receiving patients from other areas. But predominantly from metropolitan areas within Australia, followed by rural, regional, and less so remote communities. So there are a number of screening tools that are available. In terms of the distress thermometer, this is something that's used internally that helps identify and screens patients for their level of distress. This is a tool that's sent out to patients on referral, but is part of our screening as well. Just moving my face. So we've also talked about other means for referral in terms of how we can support patients. And so in terms of financial hardships, as I mentioned, the majority of patients who may or may not be working, navigating how they might access funds, whether it's through Centrelink support, superannuation. These are complex pathways to navigate, and social workers are phenomenal in supporting patients. And the earlier that we can initiate that can help alleviate some of this stress. For patients admitted during the inpatient stay, it can be quite a stressful time if there's acute toxicity. Also being apart from the family network, whether or not it's family, pet, and also, you know, just being away from regular life, essentially. For some patients, they're taking periods of leave from work, And so that differentiation between regular life and really can be challenging for some patients. So again, it's not just the patients, it's the support network. Caring for the carer is an incredibly important part of our role here. And the other important thing is that we encourage all patients coming to Peter Mac to have an advanced care directive, regardless of the intent of their therapy. And just a few additional things to flag: obviously adjustment to diagnosis, support during inpatient, but also post-acute discharge, and then in terms of the post longer-term follow-up of patients. We've touched base on our AYA group. They're a phenomenal group, multidisciplinary team that including social workers, exercise physiologists, educational, vocational specialists, music therapy, psychologists, CNCs, clinical team, and they really help support the patients that in this younger age group of 15 to 26, just before their birthday, and a phenomenal team here. You can actually have a look at their website if you're looking for more information as well. So really quickly, what can we do to optimise patients? Everything and anything. So there's good research available, not so much in the CAR-T space, that's a growing area, but we know that exercise and optimisation in all elements of life for all patients is generally beneficial in terms of their post-treatment outcomes in multiple disciplines. And so what we're looking at is how we can optimise patients in the lead into CAR-T, and in terms of their toxicity, hopefully reduce the effects, hopefully reduce inpatient stay, get them back into that into the outpatient setting and moving them back closer to their pre-morbid status. So this is an area that we're working really hard on and engaging the multidisciplinary team, and we'll be looking at developing a pathway here further in the coming months. So I'm just mindful of time. We've covered most of this. Obviously, multimodal, thinking about the nutrition needs of patients, the physical aspect of optimising patients, reducing risk factors, for example, smoking, and then, of course, infection prevention. I've also touched base on the psychosocial optimisation as well. So, arguably the most important, so caring for the carer. Sometimes it feels like the carers take second place, but they certainly should not. So the carers are such an incredible and important part of the preparation and the understanding, and in our experience, identification of acute toxicity. It's often the carer who knows the patient so incredibly well that is the one to identify new and acute toxicity. So how can we support the carer? There's a whole range of referrals that extend from the social work and psychosocial team. There's also a range of apps that can help with patients in terms of, well, families rather, in terms of using those messages or support questions from support networks. For example, feeding the dog, doing the gardening, taking the bins out, picking the kids up from school. So it's the app, I believe, I might forward outside of this. Sorry, I can't remember exactly what it's called, or I'll pop it in the chat, link in the chat shortly. And just last but not least, a prompt for our cancer school that is available online at Peter Mac. I'm just mindful of time, but you can actually Google that and I can share that link in the chat for you to have a look offline. So I think I've covered all this, and just mindful that Karen's ready and waiting, and we'll leave questions to the thread and at the end.
Thanks, Nicole. That was fantastic. And there are already questions coming into the Q&A, so I encourage people to add some more. Without further ado, I'd like to welcome Karen to share her screen and turn her camera off and present on the apheresis side of CAR T therapy. Thanks very much, Karen.
Are you seeing the full screen or presenter screen?
We are seeing the full screen.
Oh, thank goodness.
Good
Hello,
job.
everyone. I'm not very good. I'm not tech savvy at all, so fantastic.
No, you've done brilliantly. Thank you. Over to you.
Thank you very much for having me today, everyone. Tonight I'll be talking about the collection of your T lymphocytes via apheresis, the manufacturing of the CAR T cells. We didn't really discuss what we were going to talk about beforehand, so I've got a little bit about bridging therapy and lymphodepletion as well. And then I'll finish off with the administration of the CAR T cells. So I know that you've all had, well, many of you might have been to the previous sessions where you talked about being referred to a CAR T cell hospital from your local centre. And patients are seen very quickly at the CAR T cell hospitals now, and normally that would be within about a week. Sometimes we can get it down to 2 or 3 days if people are very unwell and need to be seen quickly. And then after you're seen at the CAR T cell hospital, there's all patients are presented at the national CAR T cell meeting, which involves all centres, and sometimes there can be some very robust conversations about who meets criteria, who doesn't meet criteria, and what sorts of things need to happen. And normally after that meeting, people are accepted once it's confirmed, and then the collection preparation will begin. And this is pretty fast paced. I always thought that organising a blood transplant was quick. Well, CAR Ts are like bang, 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 bang. And so that's why it's really important, all the things that Nicole was talking about earlier about support. So psychological support for the patient and the carer is really important, given that everything happens at such a fast pace. And sometimes it's very difficult to stop and take a breath and where am I in the middle of all of this. So once we know that the collection is going to go ahead, our apheresis team have a good look at the venous access. Now, when you have your CAR T cells, everyone is going to have to have a central line at some stage. But if you've had quite a bit of treatment and your veins are looking a bit sad, then we might put a central line in before you come for apheresis. Normally we normally do it either the evening beforehand or the morning of the collection, depending on where people are coming from. Then we book an apheresis slot. Now, this isn't just as easy as booking a slot because it depends on what product people are having, where they are in their chemotherapy cycle, when the last dose of steroids happen, when the last chemotherapy, or if there's having radiotherapy happening, because we don't want any of these things on board when the T cells are collected. So the lymphocytes are collected from the blood. Apheresis removes blood from the vein and spins the blood around through the machine and removes the lymphocytes, and then returns that blood minus the lymphocytes back to their body via another vein. So I've got a picture here of a peripheral venous access, and then this is just a diagram of the apheresis process on the machine. So if you are needing to have a central line, these are inserted into a large vein up over the collarbone. And then the line is inserted all the way down to just before the entry to the heart. And that's a very big blood volume, so it means with the pressure of the machine, they can take off as much blood as they need to, and then put it back into the body via the other lumen. So as you can see over here on the right, this lady has a big bore central line, and the red one is pulling her blood off, and the blue one is putting the blood back on. So this is what a machine will look like in the apheresis centre. As you can see there, this is early morning, so there's only a little bit of cells in the bottom there. But it takes approximately 6 hours for somebody to be on the machine. It's quite a long time. People can get cold, so we use warm blankets. During that time, you're not able to go to the toilet either, so bottles are provided or pans. And we have single rooms that we do the apheresis procedure in, or if there's a lot of things happening at one time, there might be 3 people in one room, so the nurse can keep an eye on everybody at the same time. So we've just had the leukapheresis where the patient's lymphocytes are collected, and then depending on which product is being used, they're either frozen here at the centre and sent off overseas, or they might be collected that afternoon and sent via plane in the hold to whichever centre it is in America that will be making the cells. And if you live in Melbourne, you may well have them made at the Peter Mac Centre. So when the cells arrive at the centre, the T cells are isolated and activated. So they're separated from the rest of the blood, and that's discarded. The T cells themselves are expanded and stimulated by an artificial inflammatory cells. And then we move over here to where the gene is inserted into the cell. So on the outside of the cell, as you can see up here, these little green areas here, is where the targeting element is. And this is the most important part, because this is where we target the CD19 for lymphoma cells and B-cell leukemia, or we're doing a lot of trials throughout Australia at the moment and hoping that multiple myeloma will come on board as standard of care shortly. So the mature B-cell antigen is another one of these targeting proteins that sit on the cell surface. And then once these have been inserted and into the cell, it's then time to grow. So these cells need to go into special medium in which they expand and keep multiplying until the team decides that there's enough cells to come back to the patient. Now, the median manufacturing time, depending on which company, it could be anywhere from 17 to 28 days. Now, during this time, patients may or may not go through some bridging therapy, and I'll talk about that a little bit. And then we get on to the infusion time. So the cells will come back from overseas, they're frozen, they go into the lab, and that's when lymphodepletion occurs. And then after the lymphodepletion, the cells are infused, and then we wait for the activity of proliferation and the killing of the targets, either the CD19 or the BCMA cells. Now, this is a living drug, so sometimes these cells can persist in the blood for several months, and sometimes we can still see them years later in our patients. So I just wanted to talk a little bit about some of the things that I mentioned with definition. So when I talk about a washout period, all of the companies have specific times when they do not want these drugs to be in their system. So either steroids or radiotherapy, immunotherapy, and chemotherapy. So that each company provides a list, and that could be anywhere from 5 days to 3 weeks without these things in the patient's system. And this is before the lymphocytes are collected, and this is also before we reinfuse. So we have to be very careful on what sort of bridging therapy happens, that we don't have to wait for like another 3 weeks after we give whatever bridging therapy it is before we can administer the cells. So it's often very complex discussions between the referring centre and the CAR T cell centre about what sorts of things should happen for bridging. So sometimes it might be that you have another cycle of whatever chemotherapy you were having before. We aren't aiming to induce a remission with bridging therapy. Basically, the goal is to temporize the disease and reduce the bulk of the disease so that we don't get progression. And we don't want to cause too many toxicities while this chemotherapy is happening, because this may delay treatment later on. We don't want people experiencing mucositis or having sepsis and having to delay until those things are sorted out. Often when people are presented at the national meeting, there might be a bit of a discussion about what sorts of things everyone would advise would be a good idea for bridging therapy. This national meeting is used by the clinical CAR T physicians as a very good discussion point. So each person is really discussed quite rigorously, and information is shared and ideas are shared with what sorts of treatment would be best for people at what stage. And then we have lymphodepletion. So that's normally a combination of cyclophosphamide and fludarabine. So those are quite low doses. And basically that is to reduce the amount of lymphocytes in the blood, in the body, so that it establishes a really good environment conducive for the CAR Ts to come into the body, expand and persist in the body. And then we have rest days. So after the lymphodepletion, there will be, depending on which product it is, can be anywhere from 1 to 2 rest days. So on the morning of the cell infusion, there's an examination, and the cell infusion in our centre anyway at the moment is done as an inpatient, and we try to do all of our lymphodepletion as an outpatient. So if people are coming from far away, then they stay across the road in the hotel, and then they come across for each day to have their lymphodepletion chemotherapy. Although some people it may not be the best for them if there are other comorbidities that we need to really keep an eye on. So those people will be admitted to our unit. So there's an examination by the medical staff or the nurse practitioner beforehand, and then a decision is made, yes, you're satisfactory to proceed. Occasionally people aren't satisfactory to proceed. They may have had a fever. So we need to check that there's no underlying infection that we need to get rid of before we start before we start the CAR T cell therapy. Now, this isn't something to get extremely worried about if this does happen, because we have 2 weeks after the lymphodepletion chemotherapy before we have to give the CAR T cells. So we've got a reasonable amount of time. And if you think about it, it's better to start somebody on some IV antibiotics and to check out to see that there's not an infection in the lung or somewhere else that we have to get rid of first, rather than go ahead, give the CAR T cells and then be in a world of trouble later on, end up in intensive care because we haven't got control of an infection when we should have. Quite often the fevers may well be disease related as well, but we need to make sure. So pre-medication is given prior to the administration of the cells, and that's usually some paracetamol and an antihistamine, and that's normally half an hour to an hour prior to the infusion. We always have 2 intravenous lines up. One is for the infusion, and we have our lines quarantined in a special area in the unit that's only used for CAR T cells and for transplants. And these do not have any filters at all anywhere in the gyp chamber or anywhere down the line, so that we make sure that there's no cells being filtered out when they're supposed to be going into the body. The other line is for fluids, and in case there might be a reaction, then we have a line that we can give whatever medications need to be given. And once all this is set up, then our checking procedures commence. So this is the CAR T cells. And as you see, this is like a clear looking bag, which is very different to the way it went away, looking like it was a whole lot of whole blood. This one is from a Gilead product, and they normally come back at 68 mils. And the other side is a push one given, and that is normally the Kymriah product. In our unit, anything 30 mils or below are given as a push through a syringe, and that will go slowly over about 10 minutes. So whoever's giving that sits down quietly by the bedside and has a bit of a chat with you while that's going slowly in. The nursing staff stay at the bedside throughout the whole infusion. Nobody leaves, and monitoring happens continuously throughout the infusion. So going over again, the cells arrive at the hospital, they're frozen. They're stored at minus 190 degrees. And then when the CAR T cells are re-infused, it's normally about 10 to 15 minutes of free flow infusion, or a slow push via the syringe, as we just saw. And that is, if that's less than 30 minutes, and that normally goes over about 10 minutes itself. And then before we give the cells the vitals, we need to have a baseline, and then we do a baseline ICE score, which I think might have gone over in one of the previous sessions. But basically we're looking for orientation, like where are you, what state are you in, what hospital you're in, naming some objects around the room, being able to follow commands like close your eyes, poke out your tongue, something like that, and then writing a sentence. And that sentence will be the same sentence that's written from that day until day 30, so that we can get it's not so much of what is written, but it is the way the letters are formed, so that we can tell if there's a change. And then attention, and that's normally asking somebody to go to count in tens backwards from 100 down to 0. And as I said, there's continuous monitoring during the infusion, and then we do vitals every 30 minutes for 2 hours afterwards. Now, we do this because there is a very small amount of DMSO, which is a preservative that preserves the cells, keeps them whole, and stops them from deteriorating when they are being thawed. But some people can react to that, and any of you that have had a autologous transplant will know the smell of sweet corn, and that is exactly what it smells like. There's such a minimal amount of DMSO in these products that smell really doesn't happen. However, if somebody is going to have a reaction to it, they're going to have a reaction whether it's a minimal amount or a lot of amount. So we do these observations over 2 hours to make sure that this doesn't happen. And then everybody gets a bit of fluid for the next couple of days, because we like our patients very well hydrated before they end up having any side effects like fevers. Thank you very much. And I think people are going to ask questions via the chat.
Thanks, Karen. That was absolutely fantastic, and certainly answered questions that I have in my mind as an allograft nurse practitioner rather than a CAR T nurse practitioner. So thanks very much for that. We do have some questions in the Q&A, and I encourage people to add some more. I'll also draw the audience attention to the chat, because Nicole's popped some really important resources in there around Cancer School and the CAR T information booklet. So Karen, while you're still, given you've just presented and while your presentation's fresh in your mind, I am going to ask a question from Louise, who says, if needed, is the central line inserted under local or general anaesthetic?
In our unit, we normally do under local anaesthetic. Some of you might have had bone marrow biopsies or other types of biopsies where you've used the green whistle. We always use that green whistle, and we have a special central line team made up of several nurse practitioners and other nurses that work with them, and that's all they do every day, all the time, is put in central line. So yes, it's under local anaesthetic plus the whistle. Occasionally, if we have pediatric people and they're young, then we might send them to theatre. And really, they're not in theatre, they're in one of the anaesthetic bays, and we have an anaesthetist that will give them something else as well.
Fantastic. And there's some really lovely feedback for you, Karen, that says, let me just grab that up for you. Where's it gone? Here it is. Thank you, Karen. Such a clear presentation, which has really helped my understanding. Thanks for that feedback, Louise. So a question for you, Nicole, from Terry. Thanks, Terry. Given description of CAR T-cell treatment as being quite invasive, is there a guideline for age limits in terms of suitability and cutoff for treatment?
Great question, Terry. So age is a number. So there's no restriction for CAR T eligibility with a numerical number for age. Obviously, there's a strict eligibility criteria about how many lines of treatment a patient has had and some of the organ functions, so heart, kidneys, liver, lung. So they're all available online. And one other thing to flag in terms of age, sometimes some units in Australia have a restriction for apheresis collection for an age limit. So, for example, in Queensland. However, patients who are outside that limit still get referred to other CAR T centres that don't have any restrictions there. So we're making sure that all patients who are eligible have equity of access for the therapy if suitable.
Thanks, Nicole. So Karen, another question for you. This is from Vicky. What is the name of the Y line you use to infuse the cells?
Oh, so it's a, golly, that's one of our general lines that we, oh golly, I don't even know the name of it now. I'm not sure. I can let, who is it? This
Vicky. Perhaps
Vicky.
we can.
Vicky. If I find out where you're from, I can always email it to you. That's no problem at all. Yeah.
Yeah. So
sorry,
Vicky, if you're a healthcare professional, pop your details in the Q&A, and we can send you that information. So there's another couple of questions I have here for you. So Nicole, in your experience, and Karen, feel free to jump in as well, because you're both really experienced specialist nurses. What are the main needs that carers flag? Obviously, you know, in your presentations, you were covering the multitude of needs that carers have, but what are kind of the major things that people come to you with saying, I'm struggling with this, or this is where I really need help, or you know, where can I find help for this?
Yeah. So one of the biggest flags that I mentioned is support and how someone might financially be able to relocate. So, for example, an interstate, that is usually the first thing that we discuss with patients and their carers to because once that's alleviated, that there's the potential for, or there's a pathway for financial support, then they can relax and actually we can progress with the education or planning sessions. So in my experience, that's the biggest thing. And the other things are really about how to keep life as normal as possible for those that have younger children. And so, for example, what do you tell them? How do you expose them to the acute inpatient admission, or do you keep them at home or use telehealth, or what days should you visit before the toxicity phase? So some of those really practical things are really helpful, and often they're usually one-on-one with the nursing team and the carer because they don't want to share their worry with their loved ones. I might throw it over to you, Karen, to see if you've got any other.
I think another big one is because everything happens so quickly and there's all this education thrown at people and it can be quite overwhelming. The main things that people remember is we're going to be in hospital, we're going to get really sick with ICANS or CRS, and then we're going home, and people forget the little nuances that were said, that you're going to be fatigued afterwards. You may have to have a lot of transfusional support or filgrastim, the GCSF injections in the tummy, and especially men, they go home and they think I should be able to do everything that I did beforehand. Or mothers, when they go home, well, why can't I, I'm so exhausted, I can't even cook dinner. And the fatigue is actually quite phenomenal, isn't it, Nicole? It really is after CAR T cells. And sometimes that can take, a month to go away. And so I always say to people, you have to be kind to yourself. You're not going to be getting in there and charging about like you used to. You have to be thinking about, right, well, I have to get up, I have to eat. I might have to have a little bit of a rest, then I'm going for a walk, and then I have to have a rest in the afternoon and then do something else later on. So it's a matter of like structuring the day, but that can create a little bit of friction or distress when you're trying to care for somebody who's frustrated because they're so tired and they can't actually get the words out to explain how exhausted they are, and I've done nothing all day, but I can't keep my eyes open or my whole body aches. So I find that a lot of my time afterwards is spent explaining all these things, and people look at me and go, oh, nobody told me any of that. Well, we did, but it sort of got lost in all the sexy things of the CRS and the ICANS and things. So the long term, obviously that's a passion of Nicole's too, but it is for me, is looking after people long term, especially beyond those 30 days, making sure that everyone understands that this is a living drug and it can go on for quite some time, and the toxicities don't just finish like they do with chemotherapy in a couple of weeks.
Thanks to both of you. I love that you call CAR Ts a living drug. It just explains them so eloquently. So there's a terrific question from Colleen. Hi, she says. Hi, Colleen. How many CAR T infusions can a patient have? Are the cells collected and sent each time, or can you use the initial collection taken? Over to you, Karen. Yeah.
Okay, so that's a very interesting question. Pediatrics, when they collect and make the cells, sometimes there are several doses that are kept by the manufacturer, and they can ask for those doses. We have had because the pediatric age group goes up to 25, we have had a young boy who had and he was 19, and so he's had 2 infusions of the CAR T cells, and that was from the initial one collection. Normally it is one and done. However, you have standard of care CAR T cells, and then there are other trials that will use another type of protein or antigen on the cell surface to target something else. So sometimes people can go on and have access to another CAR T-cell trial, and I'm sure a lot more of that happens at Peter Mac than it does with us, because you guys have loads of trials down there. But yes, most of the time one, occasionally you can have more than that.
Thanks very much, Karen. So we've only got a couple of minutes to go. And I'm just wondering, does anyone have any last questions they want to pop in the Q&A? While we're waiting for any last questions, I'd really like to thank Nicole and Karen for what's been such an informative webinar. I'm sure you agree, Ange. And I can see on the attendee list, there's a fabulous mix of healthcare professionals and patients and carers, which is absolutely brilliant. I'm going to hand back to Ange in just a sec, but what I would like to remind the audience of is the Straight and Marrow podcast. Now, coincidentally, we've just dropped season 4, which is all about CAR T. And we've dropped our second episode just today, and it's on apheresis. So if you would like to brush up on your knowledge around CAR T, I urge you to go to Spotify or Apple podcasts and have a listen to our wonderful presenters talking about CAR T in our latest episode. Now, I think there might be one. Where are we at here? So I think that's it, actually. I think we don't have any last questions. We've got a lovely comment. Thank you. Great session. So thanks, everybody, for your terrific feedback. And over to you, Ange.
Thank you so much, Yvonne, and thank you so much, Karen and Nicole. That was fantastic. I found it really informative myself, and you're both very knowledgeable in your field, which is, we're very lucky to have had you both on. I would also like to take this opportunity to thank Tour de Cure, because their support of Arrow makes this webinar possible, and for that we're truly grateful. I will also vouch for the podcast. Do listen to it. It's absolutely fantastic, and there is so much to learn from the Straight and Marrow podcast, so do jump on that. Once again, I would like to thank you all for coming along. Please take just a little minute at the end. There will be a short survey. It is completely anonymous, so please feel free to add everything that you would like. It will help us in making these webinars all the more better for everybody in the future, and we absolutely want to be able to offer our viewers a quality and informative session. So if you can do that survey, that'd be fantastic. Also, if you have any further questions, please don't hesitate to contact us at Arrow. You can find us at www.arrow.org.au, or you can email us at info@arrow.org.au. We are here at Arrow to support all our BMT, stem cell and CAR T patients and their carers. So please reach out to us or reach out to your social worker at your treating hospital, and they will get in contact with us on your behalf. So thank you again for coming along. Thanks very much to our panelists, and we will have a live recording of this, so it will be sent to you via the link as soon as it's finished. Thank you all for attending.